have a good number of people in, so let's get going. Good morning or good afternoon, everyone, depending on where you're located. Thank you for joining us today. I'm Peggy O'Brien from the SAMHSA Center for Behavioral Health Statistics and Quality, Office of Evaluation, CCBHC-OE, and I will be joined today by Sweta Palicode, who also is from CCBHC-OE. I'm going to turn it over to Sweta at this point.
Great. Thanks, Peggy. Yeah, perfect. So welcome, everyone. Thanks for joining us. I'll just go over some logistics for today's webinar. We are recording this session, and you should see closed captioning throughout the webinar. The slides, transcript, and recording for this session will be available about a week after the presentation, and we will post it on SAMHSA's CCBHC website. Throughout this webinar, you can enter questions in the Q&A chat box, as we move through the webinar, and we will address your questions at the end. We are joined today by our SAMHSA staff, Selby, who will be navigating us through any Zoom-related questions. So thanks for joining us, Selby. Next slide, please. All right, so let's get to know who all is in the webinar today. If you could take a minute to let us know which of the options presented here in this poll describe your role or roles. You may be involved in a couple of different roles in your organization. So you can choose more than one response, and the poll's opened up. Let's give it maybe 10 seconds more. All right. Okay, I think we've reached most of our participants here. Yeah, so we have a pretty good distribution. We have CCBHC-IA grantees, PDI grantees for the most part, and we also have other audience too throughout, well distributed here. Next slide, please. So the intended audience is basically everyone of you who responded to the previous poll. So prospective and existing CCBHC demonstrations, states, and clinics, independent CCBHC staff, expansion grant clinics, and SAMHSA, also SAMHSA government program officers, also called GPOs. Now that we have discussed logistics, I'll pass it over to Peggy, who will go over the agenda for today and also cover the main content for today's presentation. Peggy?
Thank you, everybody. Thank you, Sweta. So here you will see our planned agenda for today. I'm going to first do a brief 1 minute or less recap of why we're here in this series of webinars. Then we're going to dive right into areas of opportunity for clinics and states to prepare for the updated quality measure reporting, whether you're in the existing demonstration, hope to be in the upcoming demonstration, or are a CCBHC-PDI or IA that will be reporting the measures for the first time. After an overview of those areas of opportunity, I will provide as much information as I can at this point on what screening requirements are embedded in the clinic collected measures. Then we will have a Q&A with Katie Rosenthal of the Oregon Health Authority, sharing her perspective in that capacity and lessons she learned also while working in her earlier position at one of the CCBHCs in Oklahoma. After that, I plan to open it to the audience to share their perspectives on key steps you can take to prepare the quality measure data collection and reporting to meet the requirements. And we will then share the most current information on the next series of webinars in the fall and early winter. Okay, so what and why? As I indicated in the first webinar, CMS defines quality measures as standards for measuring the performance of healthcare providers to care for patients and populations. And there are several reasons why the CCBHCs use quality measures. The first is that reporting of quality data is required by the CCBHC authorizing statute. The certification criteria also require it. And most importantly, in my mind, quality measures can be used for quality improvement, as we talked about in our last webinar. They are part of the quality bonus payment structure for demonstration CCBHCs, and they can be used for evaluation purposes. Now, I want to move into an overview of different areas where CCBHCs and to some extent states can prepare for quality measure data collection and reporting. These areas of opportunity include infrastructure preparation and enhancement, addressing staffing needs, for the demonstration states and clinics, benefits of state and clinic relationships, and more generally, mutual support. Unlike some behavioral health providers, CCBHCs already have some level of IT infrastructure in place and existing EHR vendor relationships. This is a tremendous start. However, as you prepare your clinics for quality measure reporting and as you work to meet the updated certification criteria, working with those vendors to enhance and customize your electronic systems will be critical. Part of that is working to ensure that your systems capture what is needed in the way of coding, and if you're in the demonstration, to be able to shadow bill to capture services for those and other reports as well. You will want to ensure that you have systems that facilitate workflow and supporting infrastructure that facilitates care coordination, screening and follow-up, alerts, and other needs. Quality measures have implications for clinical staff, administrative staff, and data and IT staff. This speaks to the sufficiency of staffing in those areas, to addressing the willingness and motivation of staff to affect change, and to training that addresses changes, including some to workflow. Getting back to the first bullet on this slide, collecting the data and reporting the data for quality measures means that there should be collaboration across areas of expertise within clinics, including clinical, administrative, and IT. For the demonstration, solid relationships between states and CCBHCs are critical. Building in regular two-way communication and technical assistance to clinics is needed to make this work. That is important in many ways. One particular way related to the fact that in the demonstration, states also report quality measures at the clinic level. Solid information needs to go both ways. For instance, if states are reporting quality measures on 5 and 30-day follow-up after hospitalization and emergency department use, as they will be, clinics need to be doing whatever is needed to make sure the follow-up is happening and is properly documented. And states need to do whatever they must to support that, whether that's via supporting electronic admission, discharge, transfer notifications, or other health information exchange. And via doing your best to let the CCBHCs know on a regular basis how they are doing with regard to those measures that are administrative and that are calculated by the state. Needless to say, this is also important for non-demonstration clinics because care coordination and the provision of timely, high-quality behavioral health services is part of the mission of all CCBHCs. One thing that has been of benefit to existing demonstration states and clinics, as well as to the individual CCBHCs, has been formal and informal mutual support between participants. Obviously, we have formal learning collaboratives that have been assembled by SAMHSA and others. States also have worked together independently in more informal ways, as have clinics within states. Additionally, both SAMHSA and CMS maintain mailboxes where questions can be asked and responses obtained. What is important for us at the federal level, however, is to make sure that we're able to share relevant answers more broadly with all participants in the demonstration or in the discretionary grants. We did this in the past for the demonstration when the measures were initially published, with clarifications posted with the measures on our website, the SAMHSA website, and we will be looking at those and other ways to ensure that information is broadly disseminated. Before we turn to our discussion with Ms. Rosenthal, I want to take a few minutes to provide you with information on screening requirements that are embedded in 4 of the 5 required clinic-collected measures and a couple of the optional ones. I'm doing this because I know that some of you have already asked about these requirements, and this is definitely something that you can think about and work on as part of short and medium-term preparation. I am not today going to go into the timing of screening that's included in the measures or who is in the population that would be screened. That will be discussed when we have webinars on the individual measures after publication. Today will only be about what instruments you might be preparing to use. Before I go into the specific screening requirements, however, I want to answer this question, which I know many of you will be wondering about. Why are certain screening instruments required? There are a couple of reasons. First of all, nearly all of the measures that we are using are based on existing measures, which incorporate specific requirements related to evidence-based or best practices. Additionally, a large number of our measures are derived from CMS Medicaid core set adult and child measures. We are aligning to the maximum extent possible with those measures, particularly ones that in all likelihood will be required reporting for all state Medicaid programs in 2024. By aligning for many of both our state and clinic-collected measures, we will in fact be reinforcing requirements that will be in place at the state level and reinforcing requirements that are evidence-based or best practice. Among those requirements are ones related to screening, and some of the measures are more prescriptive than others. On this slide, you see information on screening instruments as included in 3 of the 5 required clinic-collected measures. The first, the SDOH, or Screening for Social Drivers of Health measure, is based on the 2023 MEPS measure, and it requires use of a standardized screen and provides 5 good examples that fit that criteria. Note that these are examples. The requirement is that it be standardized. They provide 5 examples of that. The second measure here in the second row on screening for unhealthy alcohol use provides 3 options, one of which must be used to meet the measure requirements. So not examples like the first one. The third measure on depression remission at 6 months provides 2 options, one of which must be used to meet the measure requirements. So again, not examples like the SDOH measure. And I put this one last on this slide so it's fresh in your mind when you see the next slide. Here you see a 4th required clinic-collected measure, adult and child screening for depression and follow-up plan. You also will see listed multiple examples of depression screening tools that are suitable for 3 distinct populations: adults, the perinatal population, and adolescents. As with the SDOH measure, these are examples of standardized tools that meet the measure requirements. However, given the prior slide and the requirement for use of the PHQ-9 or 9M, that definitely should be in your repertoire, even though you may have reasons at some points to use other measures. And when I do talk about these measures in the fall, I'm going to try and present these in a way that makes sense in terms of what's being collected when. So I know this can be a little confusing presented like this. So these are a couple of the optional clinic collected measures with screening components. Both are fairly flexible. The one related to tobacco use screening simply calls for screening. The one related to suicide risk assessment provides discretion based on the needs of the client, but includes certain minimum factors that must be addressed for adults and for children and adolescents during a suicide risk assessment. And while not screening, I also want to provide you with a preview of the basics of the iServe, our time to services measure. The actual details are in the specifications, but I can say this. It is based on the approach that we used with the iEval, our time to initial evaluation measure that has been in place since 2016. It calculates the average time for clients to access 3 different types of services, specifically the initial evaluation, the initial clinical service, and crisis services. These are all services with timeframes established in the criteria. The actual calculations are for the initial evaluation and the initial clinical services, uses the eligible population of new clients ages 12 and older. That is, they were not served in the past 6 months. And the measure is just the average number of days until those services from the time of first contact. For crisis services, the eligible population is clients who contact the crisis provider for a new crisis episode that is not within the past 24 hours. And the measure is just the average number of hours until those services from the time of first contact. Details on all of this will be in the technical specifications, but I know that people have been anxious to see this and to learn more about what it encompasses. So I am presenting it to you at a kind of a high level today. Also, for your information before we move on, as usual, the recording of this webinar will be posted on the SAMHSA website. I am also working to get all 3 of the slides from the slides from the 3 webinars, including this one, posted to the same website so that you can keep this, look at it, and also access links. Now, to what I know you've been waiting for, our lessons from the field. So first, I want to welcome Katie Rosenthal of the Oregon Health Authority. As I mentioned earlier, Katie has experience with CCBHCs at both the state and clinic level. So I will be asking Katie questions drawing on both roles. After we hear from Katie, however, I'm going to open it up to the audience, as I know we have many participants with valuable experience who also may wish to contribute on these questions. And these questions are fairly broad. Okay. So, Katie, putting yourself into the shoes of the clinics today, what would you want to know as a new CCBHC to prepare for quality measure reporting as you're gearing up to report for the first time?
I think some of the really big things are things that you've kind of already touched on in this presentation, such as knowing what the assessments are, and then also getting an understanding of what data is being asked for in each of those things. And I think early on, something that's really important for clinics to think about is which people need to be involved in the planning and rollout of this. Because I think sometimes the obvious is like your data analysts and the people who will be collecting that data, but your IT staff will also need to be involved so that they can implement the technical pieces into an EHR or your data system so that it can be easily collected and reported by your clinicians, but also easily pulled and calculated for the data analysts. but you will also need to have your clinical management and clinical leadership so that they can build out the policies and the procedures that will have to take place for the metrics and the data to be collected in the right way. And then also trusted staff that you can kind of rely on and get feedback from to make sure that what you're doing works for the workflow. And those are all things to consider and to think through, and that you can start thinking about even now before the technical specifications roll out of what it will look like to make sure you're collecting certain data points at the right time. And then I think some of the other really important things is kind of thinking beyond just the metrics itself, but really understanding the rationale for why these metrics were included, why they're important, clinical recommendations. And I know there's lots of resources for that. CMS has documents that are already released that provide that kind of information. The Agency for Healthcare Research and Quality has a lot of really good information about why these things are important in clinical recommendations, as well as the National Committee for Quality Assurance. And so you can start thinking about the clinical implications of these metrics that are kind of beyond just performance, so that it can get integrated in a way that makes sense for your clinicians and your clients. And it's not just a checkbox that you're doing, but it's actually really meaningful to everybody involved. I think those are things that are really important to start gathering right now and think through.
Thank you, Katie. Fabulous answer. I'll move on to the next one. So thinking about it from a state's perspective, what would you tell clinics they should focus on as they are preparing to collect and report these data? And to some extent, I think that this question may duplicate what I just asked, but if you have anything else that you want to add, feel free to do that.
Yeah, I mean, I think, again, all of the other things still apply. But I also think advocating for what you need as a clinic from the state is also really important in this frame, thinking about things of like a feedback loop, ways that the state can better support them, any questions that you have about how the state is interpreting certain definitions, or if your state has certain expectations around things. Especially because, at least from a state perspective, it's really important that all clinics are reporting in the same way. And so it's really important that you ask questions early on, and if you're and really advocate for support from your state to make sure that you have the correct understanding that's in alignment with the state for accurate reporting across the board. And then I think when tech specs come out, something that I would really encourage clinics to look at is the parameters of the metrics itself, as well as the time frame. So really being critical of who the metric is for and when you're supposed to be doing it. This will help make sure that you're doing it when it's clinically indicated for that client, and that you're meeting that metric, but you're not maybe adding kind of undue burden by trying to get everybody when that metric maybe isn't for everybody, but really being able to tailor your workflows around the people who need that metric and in alignment with that, so that there's less admin burden, but also less kind of tension when it's maybe not clinically indicated, but your policy tells you to do it anyway. And so being really critical about those pieces.
Great. Thank you, Katie. And that's something that I need to keep in mind when I do the actual webinars for the next measures, for the actual measures, is to always remember who it's for and when it's should be done. So let me move on to question 3. So as a clinic, once you see the specifications, when they're released, published, how would you go about approaching next steps?
Yeah, so I think step 1 is probably, reading through them. But I think going back to even the team, right? Understanding who needs to read those specifications and what they need to be looking for out of that, and the takeaway that they should be having with that. The people who are going to be responsible for directly collecting and reporting the data really needs to be focusing in on the really detailed things about who is included in the metric, who is excluded from the metric, what things count towards completing the metric, which things are exclusions of the metric, and really making sure they have that understanding and writing down any questions that they have, particularly around definitions. I know that first time that I eval, there was initial evaluation and first contact, and that definition originally wasn't super clear, but CMS did release further guidance. So making sure that you're staying up to date on things that are released after to make sure that your understanding of a first contact or initial evaluation is the understanding that CMS in your state also has. And then for clinic leadership, maybe looking through like what are the assessments that are needed, what are the individual data components that are needed, what assessments are we already doing, what assessments do we need to bring in, and where do these fit within current workflows that we're doing. And that's again where you would work with the staff who are on the ground doing it to make sure that what you're asking them to do makes sense with their workflow. And helping them understand too, like if there's a duplicative assessment, like how can they integrate that in a way that reduces their work and also reduces the amount of repetitive questions that you're asking a client. And then for IT, looking at those specific codes and making sure that your EHR and your data infrastructures have the ability to capture those things in a way that helps everybody involved. So it's easy for the clinicians to enter it in, and it's easy for the data people to pull it out when they need to.
Great, thank you. And lastly here, what do you see as the biggest challenges around quality measure collection and reporting, and what potential solutions might you suggest?
Yeah, I think as a clinician and working at a clinic, one of the biggest challenges that I noticed is kind of a culture shift in how we think about data and incorporate data. I know that I didn't sign up to be a therapist to collect data or think about data, and that was something that was new for me when I joined the CCBHC as a clinician, thinking through like what this data means. And then when I transitioned to admin and started working more with the data, and my understanding of that data kind of grew, I understood better how I could have used that better as a clinician. So I think one of the biggest challenges is kind of a culture shift where people are more mindful of the data and incorporating that into their clinical practice in meaningful ways. And I think just the more that you can educate your clinicians and your staff about what these metrics are doing and the utility that each of the individual data components have for both a clinician, for a client, for whatever position that you have within the clinic, the more helpful it is for you to be able to kind of move past I checked a box and like really integrate that into meaningful use. Whether it's, you know, how you manage your caseload, whether it's how you're assessing performance as a clinic. There's a lot of utility in all of these, and the more that you educate yourself on that and take the time to learn that, the easier that culture shift is. And then the other thing is really working with the staff who are doing the work. As somebody who built the dashboards, I learned very quickly that if I didn't engage them and build it out in a way that made sense with their workflow, nobody used it and it wasn't helpful. So if you're going to build dashboards to help your staff navigate these, it's really important that you get their feedback really early and work with them through the workflow to make sure that it's something that is actually useful and meaningful to them, and not just like this extra thing that they're having to look at that doesn't really help them in their day-to-day. From a state perspective, one of the biggest challenges is ensuring that each of the clinics are reporting accurately and consistently, and that they all have the correct understanding of what is included, what's excluded. And so it's really important to have lots of conversations with your clinic early on, and then ongoing. So I know something Oregon does, we have like a data subgroup, and those are the types of things that we can talk about ongoing of how is this working, and things like that to help make sure that we're all on the same page about what the metrics are and reporting consistently. And then another challenge is having a good feedback loop so that your clinics know what they're doing well, and what they could have improvement on. So having benchmarks that are clearly articulated, sending back the state-led metrics, helping them see how they're doing in comparison to others can be really helpful. And I know as a clinician, the most helpful type of information is when you can see which clients you maybe didn't collect or didn't fit, so that you can action on that. And it's not just 75% didn't, but like which of those clients did we not meet that, so that we can then go talk to those clients and work that out with those individual clients. So the degree to which you can have that type of level of information, it's really helpful, but I know that that can be really challenging too.
Great. Thank you so much, Katie. All of that was really, really incredible and valuable information. And I think you're getting lots of applause and thumbs up on the on the screen over here. So what I'm going to do is I'm going to take the spotlight off of you, and I'm going to move it over to the audience. And we're going to have an open discussion. What we're going to do is ask the audience members that have input on these questions or thoughts on these to please raise your hands. And Selby is going to enable that if he hasn't at this point. And Shweta will call on you. Hopefully we'll be able to determine the order in which you raise your hands. So let me stop talking, and Selby, hopefully you've got people raising their hands. Shweta, can you see?
Yes,
Excellent.
we do have folks here. So first, Liz Harvey. You can start.
Yeah, hi. Yeah, I'm Liz Harvey. I'm a program evaluator. I've worked with several CCBHCs across the country for a couple years now. And so what I would suggest is one of the things is to start with the end in mind. So think about what it is exactly that you're trying to measure, what types of questions are you trying to answer, who are your audiences? So SAMHSA, being one of them, who are those other stakeholders that you need to share this data with? And then from there, that should help you kind of think through, what your data strategy is going to look like at your clinic, and just think about that data workflow and who your audiences are and exactly like what types of questions you're trying to answer with the data.
Thank you, Liz.
Mm-hmm.
All right. Next we have Helen Vanderlyn.
Hi, good afternoon. So my question is about, I guess, the depression measure. So we've been collecting that for a while. We're an established CCBHC using the PHQ-9. Our enterprise is working broadly on the promise measures across the system. So we're not in that boat yet. We want to make sure, that we can potentially use other assessments to capture that information. And I don't know if, it looked like PHQ-9 was still the only thing identified, but if we're looking to see how we can try to maybe move along with our enterprise and make sure we're not missing anything crucial with this.
Yeah, that's a good question. And as you saw, there was the depression remission measure, which has the PHQ-9 basically, and I will talk a lot more about all these depression measures kind of wrapped up into one when we go through the specific measures. But that one is for people who have already been identified with depression. And then you have the CDF measures, which are screening for depression and follow-up, which had a whole array of possible examples of measures. And that is for a much broader group of people. And there is absolutely no reason that you can't use whatever measure you think is important and clinically relevant for you to use for that. And then, of course, the suicide risk assessment measures our assessments are different. So it's mainly those two that we kind of have to coordinate. But I view it as a kind of a Venn diagram. You have people to be assessed for depression who aren't diagnosed with depression. and you can use an array of measures or instruments rather, and then you have people who've been diagnosed and you're following up with them after a certain point. So you will have leeway.
Mhm.
I hope that helps. And I'll be more detailed about it when we get to the fall webinars.
Thank you.
Great. Next we have Alicia Doug-Harty. Can unmute and ask your question. Alicia, are you there? Yep, I see you
Sorry,
unmuted.
Shelly and I are on the same team. Sorry about that.
Oh, okay, no worries. Next, Joseph Turner. Joseph, did you have a question?
I just had a statement regarding some of the lessons learned here in Nevada. We were the first, we had the first approved reimbursement spa in the country for CCBHCs. And we've just gone through, or we're finishing up our second spa to kind of revisit some of the things. But my best advice to everyone, first of all, I reiterate a lot of the points that Katie made, and she's certainly a guru on that topic. But a lot of this is all configuration on the provider EHR side, and ensuring that all of this information is being collected in a manner that is easily extractable and can be done so through a automated process rather than having to go through and manually perform a lot of these processes, and making that automation so that it is changeable, as we have all of these other new measures coming out, which I'm really looking forward to the fall presentations regarding this. There's some really interesting measures, but that requires a lot of lead time on the clinic side in order to make sure that those measures are being collected in a way that they're able to be reported out upon. So I would just start this 6 months to a year before you think you actually need to, because it is very intensive, and it's also advisable to bring on a contractor that is specialized in measure collection, because it's highly specialized, and with each individual EHR it changes. So that's just my advice. Thank you.
Thank you, Joseph. Your comments are always very on point. Thank you.
Agreed. Thank you so much. Next, we have Tab Montermayor. You can feel free to unmute and ask your question.
Hello there. Good afternoon. I guess I have a two-part question, more specifically driven towards the social drivers of health measure. We noted some of the examples that were given in the previous slides, and this may be something that's on the agenda to discuss, as you mentioned, in the fall more specifically. But we're curious to see what instrument of those examples provided other organizations are choosing to adopt, or if other states' community council centers have made recommendations for which screening tool they are going to require for use. So I'd like to kind of hear from both SAMHSA if they've seen a wide adoption of those, and also some other states and organizations.
And Tab, where are you from?
We're from Texas.
Oh, okay. All right. I think it's premature for me to say who's adopted what, because my sense is that many different screening tools are being used across the United States right now. And I do think it's important that, at least within a state, that it try to be as consistent as possible. I do think that that is something that we would love to hear from others on this call now. I think we have time to do that. If there are any people who have adopted one or more of these at this point. So it's hard for us to go out of order, I think, on the hands raised, but I'm putting that out there. And so we'll see what we get. And Tab, did you have any other questions on that?
No, I guess I'm just kind of curious to see what other people are adopting, especially as the previous person mentioned, it takes time to develop and implement and collaborate with all the persons necessary to get these measures rolled out and working correctly. So we're trying to see which one of those instruments is going to be the best to align with all of our requirements.
Okay, all right. So let's continue with raised hands in the order in which they came in, and then hopefully at the end there will be others who have a response to that. So go, Shweta, if you could just identify the next person.
Alyssa Mosley.
Hi, I'm in Brooklyn, New York, and I'm new to CCBHCs, unlike it seems like a lot of people. And I'm kind of coming into one that was really not doing the things that a CCBHC should be doing. So I have a question that maybe is obvious or not. Anyway, in terms of the assessments that we use, and I saw the list on the screen, are we just free to pick one of those and use them as the required screenings, or if not, where do we get them?
Okay. As I mentioned, some of those are just examples that are included in the measure specifications, which means you need to use a standardized tool, but it can be any, and those are just a few examples. In this SDOH measure, that's one of those. It's examples. The screening for depression and follow-up plan, those are examples. They just need to be appropriate standardized measures. And then there are some, such as the depression remission, which does say PHQ-9, and the other one, the alcohol screening, which has 3 options. So those are ones where, in order to meet the measure and be counted as complying, you have to use the measures that are included. So in the fall, when I go through each of these measures in great, gory, horrible detail, I'll have a lot more information that I can share with you that will actually be up on slides that you can take home with you. And so I hope that will answer your question. But you do, like I said, from many of them, you have flexibility.
Thank you so much.
Next, we have Alice Salzer.
Alice?
And those are all the questions we have.
I do see a hand from Marjorie right now.
I think that was just a hand that was.
Oh, okay.
Yeah.
Okay. All right.
No, it wasn't two hands. Can you hear me?
Yep.
Okay, good. Okay. No, just to echo what everyone is saying, and I think I just saw in the chat a lot of people asking about the EHRs and extracting data. Like, I recommend anybody that's starting this, like, make sure you have a strong EHR. That's one of the barriers we're experiencing now, and we're on a no cost extension right now. I mean, we applied again, but that's something we're looking into, because I think when we initially got it, which was maybe 3 years ago, at the time, I think that was the EHR that, we had, and, I think at the time it fit everything, but now as everything's evolving and technology is evolving, it's like so outdated now, the EHR that we have. So, and then make sure, like, as we're shopping around, like, that's the first thing we ask, like, do you have other CCBHCs under your belt? And we try to weed out the ones that say, oh, well, we can build that. It's like, no, I want to know exactly what you have, because I don't have time to spare, like, we need to make sure that we're up and running as quickly as they can get it, up to us. So I would just recommend, if anyone's starting or looking at it, just please make sure, that they're just not talking to you and saying, like, oh, we could build it. It's like, no, show me what you have, because we just don't have time. We don't have time. We need to keep it moving. So that's what I would recommend. But this is excellent. I love what everyone's saying. So this is awesome. Thank you so much.
Thank you. Thank you. Shweta, I see a couple other raised hands.
Yes. In one moment, I see James James Kurlapalli, you can feel free to unmute.
Perfect. Thank you for let me know if I can. I think my sound's coming through.
Yes.
Yeah, so my name is James Kuzipala. I'm with Public Health Supportive Services. One of the things that we do really want to emphasize, and we worked very closely with Nevada for this, is to ensure that in addition to the data that's being collected within the EHR being accurate, to ensure that the data that's being submit through Medicaid is accurate as well. We have noticed that there have been limitations with certain vendors for submitting shadow build codes as well as diagnosis codes. So working and partnering with other agencies that have experience with that data validation is really essential. In general, once the data is submit, there are some limitations in terms of timeline for how far you can go back to resubmit those claims. And so if you realize and identify those issues a year or two after the data is, those claims have been submitted, it's almost too late, and it kind of affects all those metrics that you'll be calculating. So data validation at all levels is essential for correct quality measures.
Thank you. That's important.
We have Ali. Don't see the last name.
Hi, thank you. I'm just wondering if just wanted to confirm like reporting timelines on the clinical quality measures. Our understanding is that first reporting is due 9 months after the end of your first year. But we just want to confirm that the reporting, that's correct, and that the reporting period will be, we're reporting on the first year. That makes sense.
Yes, let me try and do this and not mess it up. 2025, calendar year 2025 will be the first measured year. Okay, so there will be a few measures where you will have to look back into 2024, maybe for a few days or a month or a little longer, but 2025 is the period that's being measured. Then after 2025, you have 9 months to get the data all assembled in the reporting template into the state. And then if you're a demonstration clinic, and then the state has 3 additional months to send that on to us along with the measures that they calculate using the administrative claims data. So it's a long time frame. And that's why we're starting to talk about it now and getting ready. But 2025 will be the first year that you are reporting on. Does that help answer your question?
And that is for demonstrations, but also what about grants, like the PDI grants?
Right. You will be on the same time frame in terms of, well, in terms of the year that you're measuring. And any look back periods, which is what I referred to. But you will be, if you are not a demonstration clinic, you will be, even if you are and you are a PDI or IA clinic, you will be submitting to SAMHSA the most current data that you have. And I swear I don't have it in front of me, but it is in the first webinar slides, which we are going to get up, but the recorded webinar is on the CCBHC website, and it's near the very end of that first webinar. I don't want to say it and get it wrong.
Thank you.
All right, so someone had their hand up. I don't see it anymore, unless I'm missing something.
Let me ask then, Shweta, is there anybody in the audience who is already collecting the SDOH screening for SDOH using one of the screeners that's in the measure? And I can kind of, let me go back to see if I can get my cursor where I want it. Okay, so the accountable health communities health-related social needs screening tool. There are two versions, 2017 and 2021. This was developed as part of a CMI pilot project. And I know that it addresses the things that are being measured in the screening for social drivers of health. The next one is the protocol for responding to and assessing patients' risks and experiences, the WellRx questionnaire, and then the American Academy of Family Physicians screening tool. And I know at some point in an earlier webinar, somebody asked about whether they could use that tool, and the answer is yes, definitely. So these are the ones, but I'm wondering, are there people in the audience who have already adopted? And I do see a hand raised. I think it's Matt. And if there's somebody else, I apologize, I can't see.
Hey, can you hear me okay?
Yep.
Great. Yeah, we have been running SDOH for quite a while now. We actually have it set to trigger every 6 months for clients in our clinic setting. We don't use formally one of these standard tools. We had actually built one that's sort of a mixture that pulls in from a few different standard tools. So some of them pull from the AHC, some of them pull from the protocol for responding to and addressing patients' assets, risks, and experiences, the prepare tool. And then a couple other of them are from just like general experience that we've had in terms of following up on clients' needs. We ran that by our state Office of Mental Health in New York, and that was approved to continue using at this time.
Okay, sounds good. And like I said, I think that we will find that people are using a variety of approaches at this point. I see Hannah, your hand is up.
Hi, yes, thank you. We are also collecting SDOH data, but I've seen in the chat as well, we are using Z codes. You know, DSM-5 approved Z codes, they're not billable, but we use them to identify the specific categories of SDOH and then the specifications within each of those Z codes to get a little bit more specific. But not sure if that would be approved as a standardized tool. And I'm wondering if that will become clear with the updated tech specs manual.
I'm glad that you raised that, because that's not something that we had actually considered. The Z codes aren't considered standardized screening. They're a way of recording what I would call not a diagnosis, but you know, something like a diagnosis on individuals. So let me take that under advisement. And I see Joseph has his hand raised, maybe as a response to that or something else.
Yeah, it's related to the social determinants of health. And I put this in the chat, but then the chat blew up. So it's really interesting to read through that. But within the social determinants of health, I am not aware of a delineation that can happen between someone that is homeless by choice and homeless not by choice. And I think that's an important delineation to make to get a true social determinant of health. Through various volunteering and going out on tours and working with a lot of the homeless population, a significant portion of them do not feel like they'll ever be suitable to live in a home, and many of them just prefer to live outside. So I think that that's an important delineation when making a true social determinant of health observation. So just some feedback, and if that could be clarified within the SDOH technical specs when they come out, I think that would be extremely helpful.
Okay, I'm actually going to write that down so I remember it. Homeless by choice. Let me just say that. Let me respond to that. To meet the measure, you're doing a simple screening that is based on these tools. And yes, some people may wish to remain unhoused and others may want housing. And that can change by the individual over time. So that is something to keep in mind. I think that is something that informs your interactions with the individual, the clinic's interactions with the individual in terms of follow through. But knowing that somebody is unhoused is what you capture with these screening tools. And I'll leave it at that. I'm going to check the time. Okay, we've got about 19 minutes left and we have a little bit more to do. I see one hand and I'm going to take that. Lauren?
Hi, can you hear me?
Yep.
Oh, hi. So I've got a question. We've been working on a modified version of the AHC tool, and I do see it listed here as an example of a tool that would be allowable. If we were to use the modified tool, is it still considered allowable standard tool? For example, some of the questions that are included, like instead of having there be 4 options, there's 3. We also added some sections to it around like childcare, criminal justice, that sort of thing that weren't previously included. Would it still meet the brief for being the AHC tool, or at that point, once you start adding or removing, it no longer would be viable?
I think that once you start changing the answer options, it ceases to be standardized. I think that also removing things, it ceases to be standardized. If you're adding things, I don't think anybody is going to object to that.
Okay.
So that's my off the cuff answer.
Sure.
I might rethink it, but that's the best the best I can do right now. Did that?
Yeah, that makes a lot of sense. So
Okay.
maybe in thinking about this moving forward for the CCBHC purposes, the sections we've added and then just leave the rest of it as was, you know. So sorry to the providers that have to answer more questions, but you know, this was based on a feeling that these additional points were needed and would be beneficial. So okay, thank you so much.
Yeah, I suspect that in different locations, different things are going to be more or less important for people. So I'm gonna call a halt to the asking questions out loud at this point. And let me get back to where I was in terms of the slides. And okay, so thank you for all of those contributions. And I know that we have 99 plus chats too. So let me give it back to Shweta, and Shweta, if you want to take it from
absolutely.
here. Thanks.
Yeah, just want to say that it was such a great discussion, and thanks to the participants for just engaging so well. All right, so I will just talk a little bit about some upcoming webinars. So these are all tentative dates. They're not final yet, and you'll hear from us sometime in August with some final dates. So in September 2023, we have 2 webinars slated for clinic collected quality measures. In October, we have 1 planned for clinic collected quality measures and another for state collected quality measures. In November 2023, we have 2 webinars just for state collected quality measures. Next slide, please. And either in December or January, we're planning to have a webinar focused on the quality measures reporting template. And we'll also use that time to have a segment just to recap major questions or concerns raised in these chats here. We'll use that time for discussion. So we can move to the next slide. That's all I have, and I can open it up for questions. I can either go through the chat, or folks can unmute, however you like, Peggy.
Why don't we, I'm going to just bring the next slide up. I would like to make sure that I get this poll done, and then I know we have many chat questions. So I'm going to have the poll come up, and then we'll go back and we'll try and take out as many of the chat questions as we can. So
sounds good.
So Selby, we're ready for poll 2. I think we're there. I think we can end the poll now. All right. Thank you, everybody. Thank you for responding to that. I'm going to hide that, put it away. And then I'm going to reverse. And okay. So Shweta, could you start and read questions from the chat?
Yeah.
Thanks.
So we already had a question about how to implement the social determinants of health measure. And I think we had a pretty good discussion on that. So I hope Tiffany found that discussion helpful. We have a question for Katie. Someone's asking if, Katie, if you could share what EHR you're using.
Yeah, so the clinic that I worked at in Oklahoma used my avatar, but here in Oregon, we see a variety of EHRs. There's Ocean, Epic, Credible, Raintree, Juniper, and I think even a clinic here that uses my avatar. So it kind of varies a little bit.
And I think the next question would also be for you, Katie. I think some helpful tips on encouraging clinics to report the data consistently and accurately. And if maybe you're, if you know of any incentives or if they're helpful at all in doing so.
Yeah, I think something that does encourage is having a feedback loop. I feel like if the states aren't working with their clinics and providing that information, it probably feels like less incentive to invest a lot of energy in reporting if it doesn't feel like those metrics are ultimately used in any way, shape, or form other than to check the box. And then I think, Oregon doesn't use quality bonus payments, but other states do, and that can be a big incentive to make sure that you're reporting accurately because you want to make sure that you're meeting your benchmarks and metrics for that incentive.
Someone asks, says they're unclear when the quality measure reporting will be due and what format it would be in.
Okay, I talked a little bit about this in response to one of the oral questions, but I can talk about the format a little bit. There is an existing format that has been used since 2017 or when the demonstration started, and that is being revised. It's being streamlined to the extent that we can. And that will be coming out. I'm hoping it would be really nice if I could get it out by the end of the year, but early next year is probably more likely, and there will be a webinar about that. So you will all hear about the reporting template and how to complete it and be able to ask questions about that. And as I mentioned before, I just don't have the schedule in front of me and I don't want to misstate it, but the timelines are in the one of the last slides in the first webinar.
And someone asked about when the technical specifications will be published, and I think you touched on it, but if you...
Yes, we're saying the fall, the early fall. That's what I'll say.
All right. How do we report on a 6-month remission if it is looking into the future for remission?
That measure is the only real outcome measure that we have. It's remission of depression. It means that you have worked with someone who had a diagnosis of depression, and 6 months after that episode started, you follow up with them. They may or may not still be coming to your clinic, and we'll talk more about this when we actually go through the specification. But it is a follow-up measure. And so the idea is that you are keeping track to some extent of the people that you've served and the outcomes that they're experiencing.
Okay. Someone's asking any information you can share about what would be considered a clinical service. Would that refer to therapy or psychiatry only, or any behavioral health services like care coordination, peer support?
Mm-hmm. So you're probably thinking about the iServe measure and initial clinical services. It's very open-ended. We used an open-ended approach for the initial evaluation and first contact. There will be more detail though in the actual specification, but it's fairly broad.
Okay. Just going through these questions. There are some responses to the chat, so I'm just trying to get a question. Let's see. Will the technical specification model be in alignment with the updated CCBHC criteria that must be implemented by July 2024 for new grantees or demo states?
The certification criteria identify the measures. And so the measures that are specified will satisfy the criteria.
Okay. I think the next question would probably be for Katie, I think. How easy or hard is it for everyone currently to extract aggregate data from your EHR?
I think that's going to vary a lot depending on the specific EHR that you use, the way that EHR has been coded and set up, as well as the skills of the people that you have on staff and the knowledge that they have with the various tools that are available to them. So it kind of just depends on what's available to you as a clinic. And it's definitely worth taking the time to invest in making sure you have the right tools and the staff to do that efficiently.
If I could, I would like to add to that. This is Joseph from Nevada.
Yes, please.
Yeah, so I think that the other key variable there is what the contract looks like with the EHR vendor and which level of the EHR they've selected. Depending on that contract, sometimes those changes are included, or sometimes there's a significant expense in any of those reconfigurations. Time is the biggest enemy there. And getting out in front of that and trying to generate those test extracts is highly advisable.
Thank you. Are there social determinants of health screening tools targeted specifically to children?
Not to my knowledge, I could be mistaken. And I believe that the specification is for adults without having it in front of me. But I am not going to swear to that. So the answer is I'm not sure, but let me check on that.
Someone says that we mentioned in an earlier webinar that there were required domains that needed to be covered for the SDOH screener, and if we could review that.
Okay. Why don't you go to the next question while
Yep.
I actually can't get into my,
oh, okay.
because I'm sharing my screen. Let me see if I can do it off the top of my head. It's the same as the ACH screener. So it's housing, food, transportation, there are two others. There are a total of 5. I'm sorry.
Okay, so next question. I think that might be for Katie. Did you experience any differences in the types of EHR systems across clinics for collecting or sharing data? Did this present any difficulty in collecting or sharing data, and how did you approach the problem? So basically, how was the data collected, and if there were any challenges with collecting the data, is my understanding.
This is James. If I can answer this one if you'd like.
Yeah.
Sure thing. So once again, my name is James Kuzipala. Yeah, in Nevada, we've worked with a lot of different EHR vendors. And what we've generally noticed is we just work directly with them to ensure that we can get everything that we want out of their system. It took a lot of effort to ensure that all the different elements were captured and especially being captured correctly. So every vendor is unique, and that is something that you need to take into consideration, especially if the CCBHCs are deciding which vendors to go with.
Thank you so much, James. Just going through questions.
I think we have time for one more probably.
Okay. When are the demonstration clinics moving to calendar year instead of demonstration year? Yeah.
Okay, calendar year formally starts in 2025. There will be a transition memo coming out or guidance that addresses this question more fully. The issue is 2024 and how to deal with that, because those of you that have demonstration years that don't coincide with the calendar year, there's going to be a transition. That will be released, I'm hoping, very shortly. And I think that probably is the last question that we have time for. You have been, thank you so much, Shweta, and thank you everybody. You've been a great audience. We had over 800 people here at the height of attendance. And I really want to thank Katie especially, but also all the people who raised their hand and shared information. Thank you, Nevada, especially for stepping up and helping. So we will have more webinars coming up in the fall. I'm going to try and get those scheduled as soon as I can. And I probably made some other promises here that I won't remember, but we are moving forward, and good luck to you all. I hope you have a nice August off from me and my webinars. Thank you, everybody.